Welcome back to the Neurophilia Podcast. I am your host, Nooper Goyle. In today's episode, we will be discussing the relationship between neurology and neurosurgery. In the early days of neurology, there was very little distinction between these two fields, and many physicians who specialized in the nervous system were both neurologists and neurosurgeons. One of the pioneers of this approach was Sir Victor Horsley, who in the late 1800s performed some of the first brain surgeries for the treatment of tumors and other neurologic conditions. However, with the advent of the CT and MRI imaging in the 1960s and 70s, the fields of neurology and neurosurgery became more distinct as each developed its own specialized knowledge and techniques. Despite this distinction, the two fields have continued to collaborate closely, with neurologists referring patients to neurosurgeons for surgical intervention when necessary, and neurosurgeons working closely with neurologists to provide comprehensive and long-term care for patients with complex neurological conditions. In recent years, advances in imaging technology and minimally invasive surgical techniques have further blurred the lines between the two fields, such as deep brain stimulation for Parkinson's disease and other movement disorders, as well as endovascular treatment for large vessel occlusions in stroke. In the 2002 paper titled Neurosurgery and the Neurologist, authors Bone and Fuller write, "As our relationship has changed, so have our perceptions of each other. We have moved on from the caricatures where neurologists regard neurosurgeons as technicians that do their bidding, or neurosurgeons consider neurologists to be investigative spendthrifts, consuming scarce radiological resources in order to diagnose disorders without treatments. We are frequently involved in the care of similar patients, but often have radically different perspectives on investigation and management. A clearer understanding of the different approaches of the closely allied specialties should improve the care of our shared patients." To discuss this and the relationship between these two fields of medicine, I have with me vascular neurologist and Neurophilia co-host, Dr. Buletko, and special guest, pediatric neurosurgeon, Dr. Julie Chen. Dr. Julie Chen is a self-proclaimed black sheep who started off as a rocket scientist only to become a brain surgeon. She completed her neurosurgery residency and epilepsy surgery fellowship at the Cleveland Clinic, followed by a pediatric neurosurgery fellowship at the prestigious Children's Hospital of Philadelphia. Dr. Chen currently serves as the Director of Pediatric Neurosurgery at Akron Children's Hospital in Akron, Ohio. Dr. Buletko, thank you for being here, and Dr. Chen, welcome to the Neurophilia Podcast. It is such an honor to have you both with us, and I'm excited for what is sure to be a very educational conversation.
Thank you.
Nooper, thanks as always, and happy post-match to everybody that's listening.
Yeah.
And Nooper, obviously, congratulations to you. And Julie, sorry to hear that you fell off the wagon and had to go from rocket scientist to neurosurgeon. Real far fall there. So
yeah, I'm just the butt of all jokes.
Good way to start things off.
She asked for a bio, and I was like, I'm going to send this. And if she tells me no, you have to actually be serious about this, I'll change it. But
I love
we
it.
are all about it on the Neurophilia Podcast, Dr. Chen. And so I just want to go straight into this conversation. And the first thing that I want to begin with, Dr. Chen, I briefly discussed your educational background and your very impressive professional accomplishments, but I'm wondering if you could tell us a little bit more about your journey to becoming a neurosurgeon. Why did you choose neurosurgery, and did you ever consider neurology along the way?
Yeah. So for me, it was relatively easy. When I was 12, my brother, who's 2 years older than I am, was helping me with my math homework. And in the middle of that, he dropped down and had a seizure. And it was the first time I had ever seen that, first time my parents had ever seen one. And it scared us, and we didn't know what we were seeing. And so to geek out a little bit, my parents, being Asian, made us do book reports every summer. Starting in elementary school. And the summer before, I happened to read the 4-volume series, American Heart Association First Aid volumes. And there was a chapter on seizures. And so when this happened, it sort of clicked that that that's what was happening to my brother. And so I just let him seize. I didn't try to hold him down. I moved all the furniture. When he was done, rolled him on the side. And while all this is going on, I'm going, Mom, call 911, like, Annie, are you okay? And I'm like, Joey's having a seizure. And so they call, and they're just panicking on the phone to the point where they can't even get their words out. And so finally, when he was done seizing, which literally only took, the longest 30 seconds of our lives, I got on the phone and I did this whole 14-year-old male, otherwise healthy, like loss of consciousness, was shaking. I didn't know the whole like tonic-clonic part of it, but I was like, this one arm was jerking and he's not conscious. I'm talking to him, he's not responding, and he's drooling now, and all this stuff. I think he's breathing just fine. He has the pulse, And that was it. That just kind of sealed the deal. And when I got to medical school, so fast forward through college and stuff. So when I got to medical school, I thought I was going to be an epileptologist. Totally thought I was going to do that. So yes, I did consider the other field. And the second part then that really kind of sealed it for me was going into anatomy lab and really being hands-on and really enjoying the dissecting and being in the lab, and realized that, for me, neurosurgery was a nice way to just put those two things together. And so I ended up going the neurosurgery route.
What a phenomenal story. And I mean, you were so impressive, even from the young age of 12 or 14. I mean, that's just phenomenal. And what a cool transition to becoming a neurosurgeon. And, going further down that route, what inspired you to specifically focus on pediatric neurosurgery?
Yeah, that's a great question. I did struggle with that because I wanted to do epilepsy surgery. As a neurosurgeon, you can't really make a career out of just doing that as a hyper focus. So I had to quote unquote, pick something else to do as well. And one of the pediatric neurosurgeons at the clinic at the time, Dr. Luciano, he said to me, Julie, at 2:00 in the morning, you have to ask yourself, what are you willing to get up in the morning? Get up in the middle of the night and go in for? Is it going to be some diabetic 45-year-old 300-pounder with an epidural abscess in their spine? Or is it going to be a 3-month-old with a shunt malfunction? And it really put things in perspective. And I was like, I'll take the shunt malfunction hands down. That's like a 30-minute case versus like a 2-hour case. And I don't want to flip a 300-pound person. No, but and what I didn't realize that came with pediatric neurosurgery was the continuity of care and the longevity of caring for patients, because you don't really get that in the adult world. And you don't see that you don't get that in residency because we didn't spend a lot of time in clinic. And so I really didn't get to appreciate that until I saw a little bit of it in fellowship. And then when I really became an attending, and I'm, more than a decade in, I've seen kids graduate. I've been invited to their baby showers. It's been really kind of phenomenal. And so it's nice to be able to do a little bit of everything and not have to super subspecialize on top of things. And so it's what I feel like it keeps my skills kind of fresh all the time. Absolutely.
Well, I love that advice from your mentor. What are you willing to get up at 2 a.m. in the morning and do? And that's amazing that you found your calling and found an area specifically in neurosurgery that you find so passionate and so fulfilling. So that's amazing to hear. Thank you for sharing with us.
Yeah, of course.
12-year-old Julie had maybe a better patient presentation than a lot of the ones that we hear from people. So that whole story was just so impressive. Anyway, thanks for sharing it. Obviously very, very personal to you and probably had a dramatic impact, I could only imagine. So, and then you said, well, why would I want to operate on something so big? I'm going to make this 10 times harder and I'm going to operate on a smaller brain because it just sounds more fun. So already I can tell that I'm not surprised from you at all.
Well, Dr. Buletko, you're a veteran on the Neurophilia podcast. You're a co-host, but our audience doesn't really know about your journey to becoming a neurologist, and so I'm wondering if you can talk us through your journey, your story, and if you ever considered getting into the OR and being a neurosurgeon along the way.
Sure. So my journey started whenever I was young. Also, I was 10, and I guess we can nerd out together on this, Julie, because I also did I did a report, and
Hey!
my mom is a nurse, and my mom worked for a private practice neurologist, and so my parents both worked. So I would go in and spend some time in the office, and I would play with spine models and the brain model. And he kind of became a mentor to me. And one year in fourth grade, when I was 10 years old, I wrote a paper on why I want to be a neurologist at 10. And so it was kind of always the joke within my family of like all my friends wanted to be professional athletes and they wanted to be astronauts. And then there's Blake who wants to be a neurologist. And so it was kind of funny and we kind of joked about it. And then, whenever I went into college, I said, I think medical field is where I would like to be. And then throughout medical school, I actually, as like an eighth grader, I wrote to Neomed. I don't know if I've ever told many people this. As an eighth grader, I wrote to Neomed and said, I'm getting ready to go to high school. I want to know what I can do in high school to get myself prepared to go into medical school, because this is what I really want to do when I want to be a neurologist. And it was kind of like I don't know what I was expecting, but I got a response, and it was probably some generic response of do everything that you can and be a good student. But I just wanted to get on the quickest path. Back then with Neomed being a 6-year program, I said, that's the fastest way that I can become a neurologist. And so it just kind of happened. I went to Neomed and I really wanted to keep an open mind of everything and really find out what I fit best into. And I just came back to neurology over and over and over again. And so it probably wasn't until some of my clinical exposure years that I said, I kind of like procedures. But then I started looking into, well, what would a procedural life look like and what would the training look like? And you and I were joking earlier where you said, I only did 8 years of post-medical school training. And I said, well, that's double of what I did almost, if you don't include my fellowship. So I think for me, I just wanted to start doing what I've wanted to do my whole entire life. And that was the fastest path. So I didn't consider neurosurgery at least seriously at all, but I like to dabble in some procedures whenever I was rotating through different services. So it's kind of been a childhood dream come true of mine, and very fortunate to have made it happen.
That is awesome. Well, I mean, you two are two peas in a pod, wanting to be involved with the brain from such a young age. It's wonderful to hear. So thank you both very much for sharing. And the next thing that I wanted to talk about, because we talked about it a little bit in the introduction, is sort of how the fields of neurology and neurosurgery have evolved over time. And I want to know from your perspective, how do your fields of medicine interact, and what are the typical interactions that you're having with the counterpart?
Well, I'll just jump right in. So we work with our neurology counterparts quite often in all fields of neurosurgery, with the brain tumors and the movement disorders, with the movement neurologists, the epileptologists in epilepsy, the stroke doctors for the vascular patients. There's a constant interplay, to the point where literally my offices are next to theirs, right, in our neurodevelopmental science center. And so they're, of course, very, very closely linked. The way that I envision sort of what their role is to me, I guess, is the way to say it, is that they help me better understand maybe the medical condition in the medical way, whereas it's my duty to understand the condition in the surgical way. And then they help me manage the patient for the non-surgical aspects of their care, and vice versa. Like, I help them with the surgical aspects of their care. And I think that the really nice thing about working closely and working well with my neurology counterparts is that when it is something, if they see something that is surgical that doesn't really belong in their office, there's a very easy channel to get to me. When I see something in my office, I'm like, well, I really think that this is not anatomically related. Like this, you need to see a neurologist. There's a very easy flow over to them. And so we interact with each other all the time.
I guess, Julie, I had one question, and you touched on this a little bit earlier, but for someone who values longitudinal care, let's say you are a referred a patient, there's something that's amenable to surgical management. You do surgery, and it's kind of a one and done surgery. There's not this kind of consistent follow-up. You don't need more procedures done. How long typically, I know it probably varies quite a lot based on what type of procedure you're doing, what type of surgery you're doing. How long will you follow patients longitudinally? I recognize that you said that that's something that you love about the pediatric patients. If there's nothing going on from a surgical standpoint, or it's medical management after surgery, how do you stay involved in those patients?
So to your point, I don't really, but I often, I would say on average, see most of my patients a minimum of 2 years in follow-up. The ones that have, like, the shunts I follow for life. And we see them pretty routinely, which is actually a different mindset than the adult side when they treat shunt patients. They don't need to necessarily see you unless your shunt's not working. I see a patient if they're well or not. The brain tumors I tend to follow, it's interesting. We have a brain tumor clinic too. So after sort of the immediate 2-year postoperative phase, they are transitioned into this brain tumor clinic, and there is a neurosurgery component to that. So neurosurgery still follows the patient, but it may not actually be me. And then things like spasticity or like vascular pumps, things like that. For the selective dorsal rhizotomies, I'll follow for about 2 years. The backlift and pumps, I'll follow for like 3 months. And then I don't see them back until they need their pump changed. And so it's interesting because I don't necessarily see them all the time, but I see them every 6 years when they need their pump done. So it's kind of like that. The run of the mill, let's say it's like a trauma, craniotomy, something like that, I'll see for about 2-3 years.
Yeah, that's helpful and interesting. And I think that you brought up a good point too, to focus on patient-centered care. So I think in the article, Nooper, that you referenced, in maybe some of the old way of thinking is, here's the diagnostician and here's the technician. They're very kind of separate things. And it's like a handoff of like, okay, it's surgical, here you go. And then, okay, I did my surgery, here you go back. It's very different than that now. And, being mostly in vascular neurology, obviously we work with our cerebrovascular neurosurgeons quite a lot. And the same exact thing is true. I'm right next door to neurosurgeons. It's not that they are in a different building, a different institute. We're all together based off of what the patient needs. And so I think shared clinics, shared patient management conferences are very, very popular. And so I find myself working more alongside the surgeons more now than what I can even remember whenever I first started training. And you used to hear about this, like one of the questions during interview season, which is interesting because we just went through interview season again, was always, well, how do you get along with the neurosurgeons, right? And, if you ask somebody this maybe 10 or 20 years ago, you'd probably get a different answer. And honestly, that question has faded a lot over the years. Now that I've been doing this several years, I very rarely get asked the question, do you all get along with the neurosurgeons? Because I think that what students are starting to see is that we actually get along really well. And now that we're focusing a little bit more on patient-centered management, we have to work together, and we have to work together longitudinally, before, during, after, all of it together. So anyway, I really appreciated the transition that's been made, and I've even seen it with my own eyes over the last decade or so.
Yeah, and I feel like, we get a lot of, and I get a lot of questions from parents about some of the neurological aspects of their medical condition. And I would just feel foolish as a caregiver in the same relative field, even if I'm the surgical part of it, not being able to answer some of those questions. And I feel like also in the pediatric world, you're sort of dealing with the parents and dealing with the patients at the same time, and they're two very different entities, even though they're related. And so I think that adds to at least my desire and the way that we practice neurosurgery here, of a more of an emphasis on really kind of understanding the disease processes that we are treating. I will say that when I was at the clinic, Dr. Gonzalez Martinez, I don't know if he was there when you were there. He came from Brazil. He had just come from Brazil. So he was redoing a fellowship and then was redoing residency, but he had done a neurology residency in Brazil. And his knowledge of neurology was so, as a neurosurgery resident now, was so impressive. And he was just so knowledgeable that's what I wanted to be like, right? And you can't be that way unless you know your diseases, but also I think there's a certain like passion that you have to have about what you do as well. That's probably getting into some of the later questions.
Yeah, well, Dr. Chen, you gave my transition for me, so which I appreciate so much. As we talked about in the introduction, this paper that was published in 2002, the Neurosurgery and Neurologist article, they talk about how, the difference between neurosurgery and neurology, a lot of it comes down to differences in decision-making, differences in clinical evidence, as well as diagnostic certainty. And so you both have already sort of talked about how you learn from the other specialty, but I'm wondering if you could talk more about, what you truly on a day-to-day basis get from your neurology or neurosurgery colleagues and how that over time has influenced the way that you provide patient care.
So I think one of the best examples of that is with the epilepsy service that we have. I certainly need their input as far as what their seizure burden is, what is my target, what are we trying to treat, right? Because, it's very, not that it's rare that neurosurgery for epilepsy is curative, but we don't really use curative quite that often. Frontal lobe epilepsy, temporal lobe epilepsy, lesional, non-lesional, whatever. And so because of that, we have to set very, very clear goals for surgery. And those goals are really dependent on the epilepsy side of things and the neurological side of things. And so those are, it's very helpful for me to know semiology, to know what the EEG shows, to know what meds they are on, to know what they have failed, to know all those things that I get from my epileptologist. It's also helpful for me to understand what they think the prognosis is after whatever surgical intervention we can potentially offer. Not saying that they tell me and that's what I tell the family, but we have that conversation together, right? Because I'm bringing to it, well, this is what happens after I take that part of the brain out. This is what happens, and so it's this back and forth dialogue. I think that in the end really lends itself to informed consent for patients, because you want to make sure that they really have a understanding of a very potentially complex situation before they say yes or no to what you have to offer. Does that answer your question? I feel like you have multiple parts to your question.
I mean, it definitely does. I guess like the later part of it is like from this close collaboration that you've had with, people specializing in epilepsy, like how has that changed the way that you practice medicine? Has it just made you more knowledgeable, or does it influence the way that you provide physical exam? Like how has that influenced you?
So it has made me more knowledgeable for sure. I think that I can have better conversations with families as far as what to expect afterwards. I also think that it helps with the conversation, and in the past where it was sort of I'm just the scut monkey that does the surgery, right? Now it's much more of a conversation. It is back and forth, and I think that just adds value to the multidisciplinary conferences, because it's there's a big difference between the surgeon that kind of just sits there and listens, and the epileptologist says, this patient needs a VNS, put a VNS in, and there's no conversation about it. It's like, okay. Versus a conversation of, this patient should get a VNS. It's like, well, these are Lennox-Gastaut. Have we thought about a corpus callosotomy? What have you talked to the family about? Because for me, then it's part of also making sure that you offer all of the possible treatment options, rather than just offering the one that you are familiar with.
Yeah, I couldn't agree more. And I think you beautifully stated whenever you were talking about how it's now more of a continuum of a conversation rather than this like, well, you have to ask the surgeon that. And then it's like, well, you have to ask the neurologist that. And I could only imagine as a patient, you're just like, well, I feel like I'm treating two different things, but this is me. This is what I am going through. And so I feel like us being on the same page, now I know whenever I approach my patients, one, I know what's possible sometimes, not always. The surgeons always surprise me with what's possible and what's not. But sometimes I know how to lead into that conversation of saying, for instance, a lot of the surgeons that I work with in stroke patients, it's usually surrounding some sort of EC-IC bypass or something to help with a chronic occlusion or an acute occlusion. And it's, well, I can now talk to a patient about, here might be some of the options that we have because I've seen my colleagues do this. Here's what to expect whenever you meet with them and have that conversation. Here are some of the things that they may talk to you about. And then here's what you can expect after the fact. And I think that as we know more and more about the same disease that we're treating together, the patient and their families, they're getting a consistent message. It doesn't sound like we're not talking to each other. There was one case that I can remember in a patient who had a distal common carotid occlusion that was affecting the ECA and the ICA. And this patient was having recurrent strokes. And unfortunately, in order to bypass what needed to be bypassed, initially there was a tandem occlusion. So it was a distal carotid and then also an MCA. And so the thought was, is the MCA symptomatic or is it this distal common lesion that was symptomatic? So after we do angios and MRIs and perfusion scans and all of this, ultimately, I said, I don't know what we're going to be able to do here. And I had a conversation with the surgeon, and we did an angio, and the STA branch where we would usually use for a bypass, it was too small because it wasn't getting a lot of flow from the ECA. And so I don't want to get too technical here, but ultimately what ended up happening is they said, why don't we also involve vascular surgery? Why don't we do a subclavian to ECA bypass so we get around that and then plump up that ECA so then it's ready to do the ECA or the STA to MCA bypass.
Yeah.
And I was like, I would have no idea that this ever existed to be able to do. And so us knowing, what needs to happen and then talking with our surgical colleagues to just say, oh my gosh, like, look at what we can do nowadays that we never were able to do before, and how creative and how thoughtful to really go through this together. And it made a big impact for this patient. So I can give you a bunch of examples like that, but I just thought that it was really remarkable and took us in a completely different direction.
I absolutely love that example. And I love the way that you put it in terms of like possibility, that being able, like the collaboration just makes you so much more aware on both ends. And when it comes to being patient-centered, it's much more approachable to the patient, that you feel like you have a whole team trying to fight this one diagnosis rather than a couple people on opposite ends, which can make things a lot more confusing for the patients that we deal with. So I really appreciate that answer, Dr. Buletko. And, I'm curious also, with the growth of fields such as interventional neurology, with endovascular therapy in general, how do you think that the relationship between neurology and neurosurgery has changed and will continue to change over time?
I mean, I've only seen it improve and be more collaborative than ever. Now you have, traditionally in the past, interventional neurology was mostly radiology and neurosurgery. And now, neurology has crept into that too, where you have a lot of neurologists who are neurologist training, go through neurology training and then go into interventional, neurology. And so I think having everybody together and looking at a group of people that are all doing similar procedures to some degree for acute stroke therapy, at least, and you have radiologists and you have neurosurgeons and you have neurologists, you want to talk about a lot of brain power working together to take care of patients. Like, I don't know what better combination of people you can have for that patient population. And so I think it's been really remarkable. And I've only seen it increase collaboration over time.
Yeah, I would agree. I think that it increases collaboration and increases access to care for patients as well, because there's no way that you are going to be able to train enough neurosurgeons only to be able to cover that amount of patients that need acute stroke care. It's too much for the number of neurosurgeons that a typical place would have, right? And so you have to use your colleagues. It's great to have colleagues, I guess I would say, that also are able to do that and to treat that disease and have a great understanding of the disease process, right?
Yeah, I was about to say, I mean, like if you have a neurosurgeon and a neurologist tackling a similar issue in the same field, I mean, imagine the difference in approach, the brain power, as Dr. Buletko put it, that goes into that. I mean, that only furthers patient care. So I completely agree with both of you. And I wanted to move forward and sort of talk about medical education, as that is a large part of this podcast. And Dr. Buletko, being a program director of a very large neurology residency in Cleveland, I'm wondering if you could talk about the level of integrated or interdisciplinary training available at the residency level for these two fields of medicine.
I think there's definitely some integration, from whenever I went through training. What I remembered most is the shared rotations that we had, neurosurgery residents. And I'm not sure, Julie, if you went through this, but they used to rotate on stroke service with us.
Mm-hmm.
They no longer do. So maybe that was because Julie said, no longer should we be doing this. I'm not sure, but when we rotated through the neuro ICU, I know the surgeons that I know now are the people that I work closest with in the neuro ICU together, where we were managing patients together. And I think it's this kind of organic relationship that you develop just by talking about patients, and you hear their perspective and they hear your perspective. And so I don't think it's necessarily like a shared didactic, because I think that we approach things a little bit differently from that standpoint. But I think it's those interactions that you have. Obviously, as a trainee, you're working together, you're consulting each other all the time. And so there has to be that collaboration early on. And so I think when you're so used to working with another specialty, it's just natural to continue that relationship as time goes on. And you're going to rely on each other for the rest of your life. So you might as well get used to it during training, and how to have that interaction and how to create those relationships. And so maybe there could be a little bit more. I don't think that they want us going into the OR with them for a lot of different reasons. I wish that I would have had more exposure to see what they did day in and day out, to be honest with you. I think it would have also enhanced my own understanding of some of these surgeries that they're doing. But it's probably best for everybody involved that they don't have a bunch of neurology residents trying to run around the OR with them. But I found that most of my interactions, the most meaningful ones, were the ones that happen organically when you have shared patients.
Yeah, I agree. So I got to tell you this great story. So when I was a PGY2, I started in the neuro ICU. That was my first rotation, and I was on call first day, July 1. And the stroke senior, whom I didn't know was the stroke senior at the time, comes walking into this ICU in 4-inch stiletto heels. Now, mind you, it's like 2 a.m. And she looks at me. She goes, "Are you the resident on?" And I said, "Yes." And she goes, "I need a room." And I'm like, "Who is this?" Right? The hell do you think you are? You need a room in my ICU. Adrian Boise was the stroke senior. And so Nooper, I don't think you've had the pleasure of meeting her, but Blake, I'm sure you know who she is. And she is this stunning 5'10", gorgeous blonde ballerina stroke neurology. She's an MS doc now, but she was the senior at the time, and just this was this love-hate immediate connection to this person. And so, yes, I rotated on the stroke service. She was my senior, actually, when I was on the stroke service. I've done things like the neuroradiology elective and things like that. And I think that, and I'm a little more old school, right? So when I was an intern, the 80-hour work week had just started. So that's how old I am. And I think that there has been a loss of knowledge and a loss of education, as with the time constraint, the excuse was with the time constraints, they have really kind of honed in and refocused electives and rotations to really just be on neurosurgery, which is really unfortunate because I think that they lose out, right, on learning the medical side of the disease processes that we're expected to treat and expected to be the experts in. And so I hope that there is a way to kind of bring that back in. I know they get some of it. I think they get some of it still on the neuro ICU rotation, but even then, I think that's pretty limited now again. We used to rotate through the ICU twice. So it was 3 months twice. So it's 6 months, which is not a short amount of time to spend. And you do it young and you do it older, right, as a senior resident. So you kind of get that difference in roles the second time around. But yeah, I definitely rotated through the neurology service on a couple of different services, and it was a good time.
I love the way you put it of it being a love-hate relationship with neurology.
She's one of my best friends now, which is kind of funny, but I was like, like, who is this person?
in the beginning. Now it's just a love-love relationship, which is
it's totally a love-love relationship. Yeah.
Well, Dr. Chen, the focus of the first season of Neurophilia is obviously to help eradicate neurophobia, which is the fear of clinical neurology experienced mostly by medical students, but also young doctors. And I'm sure clinical neurology would probably also assume neurosurgery as part of it. And so, I first want to ask you, as a pediatric neurosurgeon, do you experience neurophobia? Or have you in the past?
Well, I did as a student, right? I did as a student, as I did as a resident even. And I think that when we are residents, there's this Wednesday morning conference. It was called PIMP conference because they were basically trying to mimic the oral boards. And the younger the resident you were, the more you just got picked on. And so if you were wrong, I mean, they just led you down this rabbit hole and you just embarrassed yourself in front of all of your residents, all of the attendings, any guests, things like that. And so 100,000% experienced the fear of speaking up, right, about anything neurological, neurosurgical in front of other people.
Okay, now you opened a rabbit hole. How did you gain that confidence when it came to neurology and in your practice?
Oh my gosh, it took so much time. So I think there was a couple of things that played into that. One is the knowledge is there, right? You read, you study, it's repetition, it's recognition, it's all those things. You go through your training, the Cleveland Clinic. I have to say the Cleveland Clinic it's a great training program. I do. I love it. And I think what really held me back was this whole feeling of imposter syndrome and feeling like I just wasn't as smart as the other people in the room. And that's really what it was. And being the only female in the program for a while, I really was sort of an outcast. And it took a long time to realize a lot of things. One is you belong in the room because they pick you, right? The other thing is that being female, for me, being female didn't mean anything. It should not have been any different for me or for anybody else in that sense. What I'm trying to say is that I was just there to become a good neurosurgeon. It didn't matter to me that I was female. So I wasn't there to make a point. And so it took, so this is what I was getting at. I was like, I had lost my train of thought for a hot second. What I was getting at was that I spent so many years then trying to fit in and trying to belong so that I could get that feeling, get over that fear, right? And it turns out I'm never going to be one of them. So it completely changed when I was able to then find my own way as myself in my field, doing what I do that I love, and then gaining that confidence from there and getting rid of that imposter syndrome.
I think, I mean, I absolutely love that. And you are just so impressive, Dr. Chen. And especially when it comes to medical students and especially young doctors, that imposter syndrome is so prevalent. I can speak to that feeling right now myself on the precipice of becoming a resident doctor. But I think when you have that imposter syndrome of, oh my gosh, I'm going into medical school, there's so much going on, coupled with the complexity that is neuroanatomy and, the fact that neurology is a complex science, we've talked about that before. It can be very overwhelming for students and for resident doctors. And so I appreciate your perspective of how you were able to gain that confidence. And so I'm wondering, from all of your experience, what do you think we can do as neurologists, as neurosurgeons to help eradicate neurophobia in the medical community?
Oh my gosh, eradicate neurophobia. Ugh. You almost have to undo society stereotypes from like decades old society stereotypes, right? I think part of the fear of, at least my perspective of it, and Blake, feel free to chime in because you've been pretty quiet.
I'm taking it all in. I have some thoughts, but you're just you're on a roll, and I love listening to it.
So from a neurosurgery perspective, I sort of feel like people are afraid because we have a reputation for being not so nice. And that stereotype still carries on, right? And so when I don't like actually telling people what I do, because once I do, there's this immediate wall goes up. And it's like, oh, you must be really smart. And I'm like, no, I'm not really that smart. Like, I just like what I do, right? People are good at what they do if they like what they do. And then the second comment's always like, well, you're not a jerk though. And it's like, well, there's some of us non-jerks out there doing our thing. So there's definitely this persona, and the field attracts that persona too, right? It really does. And then you're sort of you're around people that are supposedly the best of the best, the smartest all the time. And there's ego, and they're just constantly trying to compete against each other. And then you're a student watching this happen and watching this interplay. And then you think that's what neurosurgery is, or you think that's what neurology is. And of course it's going to be so, unless you can hack it, like why wouldn't you be afraid of that? Right. So, but I feel like there's a lot more empathy in medicine now. I feel like there's more compassion in medicine, and there's more sort of focus on mental health and wellness and all the other things that we used to joke as, you don't sing Kumbaya in neurosurgery, but now we're actually kind of like having to sing Kumbaya in neurosurgery. And so I'm hoping that it's changing. I think that once you start inundating the field with like nice, normal people, it will start to change as well. And neuroanatomy is intimidating. It is. It's a lot of memorization though. So I think so for me, like I found pharmacology to be very intimidating, and I didn't like it because I thought it was just rote memorization. So I think it's to each his own kind of a thing. Some people like memorizing neuro-based stuff like I did, and some people understand neurophysiology easier than they understand, like pulmonology. I got lucky. I passed. So, it just didn't click, right? It didn't click. So if we can figure out a way to teach neurology, neurosurgery, neuroanatomy, neurophysiology, I think it's also good, in a way where it just clicks for people, I think that we will be able to attract more people to the field. But it's not an easy topic, and it shouldn't be.
Julie, that was going to be my follow-up question is, and we talked about this on one or two of the other episodes, is how do you make it easier per se without losing that love of the complexity of neuroanatomy, neurophysiology? I think that's why some of us are so drawn to it, but it's also why a lot of people run away from it. So my question is always, how do we make it easier for the majority, but we who really love that aspect of it, how do we hold on to that? And you don't have to have the answer. It's just a perpetual thought that I have whenever I talk to students and residents, and whenever we teach our colleagues in internal medicine or other specialties of medicine, I always wonder, how can I make this easier without losing that love of how complex it can be?
Yeah, so I've found that I feel like the best teachers that I've had in my life were the teachers who really knew their stuff, like really knew their stuff inside and out, right? Same thing with the surgeons. The really, really good surgeons were ones that could get you out of trouble. And so, as you know, there's varying what's the word, qualities in providers and and teachers in all professions, right? Medicine is not, you know, numb to that, and medicine is no exception, right, to that. And so I feel like as educators, we owe it to our students and our residents to really know our things. And the way that I teach my APPs, and so I don't have residents, but I have APPs. And I teach the APPs like I would otherwise teach residents. And I say that they're like, read, I'm only reading. Well, I was like, no, you don't understand. I was like, you have to read to the point where you can teach me what the book says. That's when you know the information, because that's what your patients are going to expect you to know when you talk to them. So if you can't recite that chapter to me, if you can't give me a summary of that chapter, you don't know the stuff yet. And that's the kind of standard that I held myself to. And I think that's what we owe to the students as well, is we have to be able to, now some of us wrote those chapters, right? So we should be able to do that. And I think that there's a certain energy. Do you remember Ben Stein? Was it Ben Stein? What was it? The eye guy, the dry eye guy? Bueller, that guy?
Yes,
yeah.
yes.
If you teach neuroanatomy like that, no one's going to love it. And then you're going to kill the passion for somebody who went into the class loving it, right? But if you teach it like if you teach it like me, you're drawing little cartoons on a whiteboard. I called them paper napkin sessions, because we'd be sitting in the cafeteria. I'd be with a medical student or a resident. I'm like, we have 20 minutes. Let's learn about something. So I'd grab a paper towel, and start drawing on it. Talk about meningiomas. Let's talk about shunts. Let's talk about siphoning. And just do these short little bursts, but to draw it out, right? And you have to know it well enough to do that. So I don't know if that's a long-winded answer. I don't know if it actually answered your question, but I hope that we continue to attract people who really love the field, so that they really love learning about it and staying engaged with it.
I loved it. And, obviously we can edit out, but
Yeah, okay.
I think what you said about, if you know it well enough to teach it, like that is such a good model. And if all attendings and residents and future doctors that are current medical students, like had that approach, imagine what medicine could be like, that is truly powerful. So thank you for that, Dr. Chen.
I love the short bursts too. I think that, maybe you gave me a little answer to what I struggle with sometimes. And I think your approach to, and I do this all the time, but I never thought of it as, you can make it a little bit easier if you know what the high yield information is that you want your learner to take away. And if you can teach that to them in a very quick session that's interactive, then great. And then you're giving them some pieces of information that they can't forget, because you made it so easy for them to remember, that you're almost implanting neurophilia, without them even knowing. So I love the answer. And I think I need to be more, I think we all do it, but I need to be more intentional with how I'm doing that. So that's helpful for me as well. So thank you for that.
Oh, good. Of course.
Well, Doctors Buletko and Chen, it has been such a pleasure, such a true pleasure talking with you both today and hearing your perspectives on the relationship between neurology and neurosurgery. I want to thank you for your time, truly. And before we conclude, I want to ask you, Dr. Chen, about your no-brainers. And these are
like speed rounds, right?
Yeah, these are 5 rapid fire questions that you can respond to with 1 word or 1 sentence maximum.
Nooper, can I interrupt? I've never interrupted your no-brainers. Can I change out your second no-brainer with my own?
Oh, absolutely.
Sorry, Julie, I'm going to throw you a quick curveball.
Oh
It'll
my
still be
gosh.
related, but
Not prepared. Okay.
yeah, you said a couple of things that makes me want to ask you a specific quick question. That's all.
Of course.
Okay.
Of course. I'm ready.
Okay.
Because we can edit this, so.
Yeah, we can edit it. We can take as many takes as you need. All right. First question. What was your favorite part of this conversation?
My favorite part was being able to kind of be a little nostalgic and just retell stories from training and sort of remind myself of the love of why I do what I do and how I got here. That was fun for me.
Awesome.
So I get this one?
Yeah.
All right. Julie, I was curious, you being somewhat of a trailblazer for women in neurosurgery, I want to know, we've made a lot of progress. We have a long way to go. If you could give one piece of advice to a young woman who's interested in neurology or neurosurgery, what would it be?
I would say don't be afraid to be authentic to yourself.
Beautiful.
Thank you.
What do you hope changes in medical culture?
I hope the way that society views the medical responsibility to the community changes. That's my single sentence answer. There's a lot of depth to that answer.
Yeah.
It is getting harder to practice medicine with the confines of regulations and financial restrictions and things like that in this day and age that I've even seen change, and I've only been in practice for like 12 years. And so 11 or 12 years. And I wish that the public understood our side of things and what we were trying to do for them, to then be advocates for themselves to the people making the regulations.
I was giving you Zoom claps, so I didn't interrupt while you were saying it, but agree.
Wow. Gosh, just lost the earbud. Okay, here we go. I'm back.
Who is your mentor?
So honestly, I have two. I have Dr. Bingaman and I have Dr. Sutton. So Dr. Bingaman is an epilepsy surgeon at the Cleveland Clinic, and Dr. Sutton was the chair of pediatric neurosurgery at CHOP when I was there. He's since retired.
And what are you most proud of?
I am most proud of keeping my sense of humanity while being a brain surgeon.
I absolutely love that answer. I absolutely love that answer. Thank you so much, Dr. Chen.
Of course. It's my pleasure.
So in this episode, we discussed the fascinating history and relationship between neurology and neurosurgery, and I hope the audience can appreciate the close collaboration and mutual respect between these two fields of medicine, as demonstrated by our wonderful guests, Dr. Buletko and Dr. Julie Chen. Thank you so much for listening, and if you enjoyed this episode, please leave us a review and share it with a friend. Make sure you follow us on social media at Neurophilia Pod for updates on future episodes. In our next episode, we will be discussing the relationship between neurology and medicine. See you then.